Hello, everyone. My name is Caitlin Bavislaski, and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm pleased to welcome you all to today's educational webinar hosted by Lymphoma Canada at our conference on Hodgkin lymphoma. We appreciate those of you who have been able to join us live today to learn a little bit more about the disease-specific biology of Hodgkin lymphoma, to understand more about the current Canadian treatment options available, and also understand newer treatments coming to the Canadian market and the research behind these new therapies and clinical trials. Now, before I go ahead and introduce today's speaker, I'd like to provide a bit of guidance about the Zoom software. This virtual software does not allow for you to share your video or your microphone. If you do have a question, please save it for the Hodgkin lymphoma Q&A session following this breakout presentation. You can then ask your questions to the presenter live. I would now like to go ahead and introduce and welcome our speaker today, Dr. Alfonso Rivera. Dr. Rivera is a staff hematologist at the St. John Regional Hospital in St. John, New Brunswick. He's involved in the care of patients with blood cancer malignancies, and his main area of interest includes lymphoma, myeloma, and autologous stem cell transplant. We thank you very much for joining us today to speak on this Hodgkin lymphoma subtype, and we would now like to turn over the presentation to you, Dr. Rivera. Thank you, and take it away.
Thank you very much for your kind introduction, and thank you very much to Lymphoma Canada for the invitation, and especially thank you all for attending today my talk. So today I will talk about Hodgkin lymphoma. We're going to focus on current and future treatments. My disclosures, I really have no financial conflicts of interest to declare. Before we go ahead and talk about treatment, we're going to talk briefly about the background of Hodgkin lymphoma. As we all know, Hodgkin lymphoma is a cancer that originates in the lymphocytes. And the lymphocytes are a type of white blood cells that are found mostly in the lymphatic system. And the lymphatic system is built of these different types of lymph nodes, lymph vessels, and lymphoid organs, like the spleen, the tonsils, and the bone marrow. And usually the lymphocytes, they originate in the bone marrow, but they migrate and they spend the rest of their days in the lymph nodes and in the rest of the lymphoid vessels. There are two types of lymphocytes, the T cells and the B cells. And Hodgkin lymphoma originates from abnormal B cells called Reed Sternberg cells. From the histology perspective, we can divide Hodgkin lymphoma into different types. One is the classic Hodgkin lymphoma, that it compromises more than 90% of the cases, and it's going to be the topic of today's presentation. And also exists a nodular lymphocyte predominant Hodgkin lymphoma, which is very rare and is just less than 5% of all cases. It's important as well to keep in mind that Hodgkin lymphoma is a relatively rare type of cancer. It represents around only 10% of all the lymphomas, and in Canada, every year are about 1,000 cases diagnosed of Hodgkin lymphoma. If we see that graph in the right bottom corner, Hodgkin lymphoma represents only about 0.5% of all the cases in the United States, although Canadian data is very similar. Hodgkin lymphoma is usually a cancer of younger people. The median age of diagnosis is 39 years. However, there's a bimodal presentation in age. The first peak is in between the 20s and the 30s. And there's a second peak later in life in 70s and the 80s. And as we see, it is slightly more frequent in men than in women. Regarding the risk factors, there is very little known about what causes Hodgkin lymphoma. We do know that there is an association between EBV, or the virus that produces mononucleosis, and Hodgkin lymphoma. However, we do know as well that more than 90% of the population can actually be infected with EBV, but only a tiny fraction will develop Hodgkin lymphoma. And the factors related to transformation to Hodgkin are unknown, really. As well, there might be some genetic factors involved, and that is especially seen in tweens. In terms of the presentation of disease, the most frequent manifestations are enlarged lymph nodes. They're present in more than 70% of the cases. As well, between 30 to 50% of patients, they do have lymph nodes in the chest or in the mediastinum. For reasons that are unknown, when people drink alcohol, these lymph nodes can be painful. But other than that, the lymph nodes are usually not painful, and they're hard consistency. Also, about 1/3 of the patients they develop something called B symptoms, which includes fevers, chills, drenching night sweats, weight loss that is non-intentional, and progressive and profound fatigue. Also, patients can develop itchiness in the skin without any evident rash. And as well, when people have involvement of the chest, they can have cough or progressive shortness of breath. Then the most fundamental aspects of Hodgkin lymphoma is actually have a correct diagnosis, as this is fundamental to have an appropriate treatment. And often the diagnosis can be challenging. And the best way that we can help the pathologists to have an appropriate diagnosis is to provide them with good biopsies and with good material. We do know that fine needle aspirations are not recommended and they should not be used for the diagnosis of Hodgkin lymphoma. Core biopsies can be useful, however, sometimes they might be insufficient. The best biopsies are the excisional biopsies. However, these are more invasive and sometimes they carry a higher risk compared to core biopsies. Now, if we look under the microscope, on the left image, we see the classic Hodgkin-Reed Sternberg cells, which are these very large cells that have this characteristic 2 nucleus. If we see the image in the right side, this is a very characteristic case of Hodgkin lymphoma in which we see that the Reed Sternberg cells are only a fraction of the total population of cells that we can find. And one of the most important aspects and has treatment implications are actually the rest of the cells surrounding the Reed Sternberg cells. The cells that surround the malignant cells are usually cells, inflammatory cells, mostly T cells, other B cells, monocytes, and macrophages. And we're going to talk to them about them in a minute. Now, after we have a diagnosis, the next step is to have a proper staging. Modern staging methods include the PET-CT scan, which is the ideal staging method. And this is because it provides with the most accurate information. In cases where a PET-CT scan is not easily available, CT scans are still a good alternative. Also, bone marrow biopsies that were done to all patients some years ago are not necessary anymore when PET scans are done. And the only reason of why we should consider bone marrow is when we have unexplained low blood counts. Also, your oncologist or your hematologist will request a baseline blood work. Some patients might need an echocardiogram to assess the function of the heart, and a pulmonary function test are usually requested for some patients. Now, once we have the staging, the initial PET-CT scan, the next step is to actually do a formal staging. And there are 4 different types of stages in Hodgkin lymphoma. Stage 1 involves just a single lymph node site. Stage 2 involves 2 or more lymph node regions in the same side of the diaphragm. Stage 3 involves lymph node regions on both sides of the diaphragm. And the stage 4 involves disseminated disease to 1 or more extralymphatic organs like the liver, bone marrow, or lungs. Also, do additional designations that apply to any stage. That includes the letter A, when patients have no symptoms, B, when patients have fever or night sweats, weight loss, or B symptoms in general, E, when there is evidence of extranodal involvement, or S, when there is splenic involvement. And here we have um, a cartoon that exemplifies better the staging. We see again stage 1, single lymph nodes, stage 2, two or more areas under the same side of the diaphragm, stage 3 on both sides of the diaphragm. Remember that the diaphragm is the muscle that separates the chest from the abdomen. And stage 4, again, is widespread disease. Also, once we have the staging, the next step is to understand if patients have or do not have some of the favorable risk factors or the presence of unfavorable risk factors. So we classified as early stage when favorable when patients have stage 1 or 2 with no risk factors, or early stage unfavorable when they are stage 1 or 2 with one or more of the following risk factors, which are a large mass in the chest, usually more than 1/3 of the diameter of the chest according to the images, more than 3 lymph node regions affected, the presence of B symptoms, extranodal disease, or a blood work that's called ESR, more than 50 or more than 30 where there are B symptoms. And these factors only apply for stage 1 or 2. For advanced stage or at stage 3 or 4, we use the International Prognosis score, which is the IPS, and it gives points for being male, being older than 45, having stage 4 disease, low albumin, low hemoglobin, uh, high white blood cells, and a lymphocyte count less than 8% of the total white blood cells, or a total number of 0.6. Now, when it's time to treatment, it is very important to keep in mind that the goal of the treatment of Hodgkin lymphoma is cure. However, cure rates, they do vary according to staging, age, and comorbidities. Age and comorbidities usually are important at the time of choosing the right treatment, as younger patients are able to tolerate intenser chemotherapy far better than older patients. Um, and one very important thing to keep in mind is that the treatment for Hodgkin lymphoma has significantly improved over the last decades. In the old days, MOP and radiation were used. We're talking about the 60s and the 70s. And this combination of treatments lead to the first cure rates. However, over the years, physicians notice significant side effects related to the use of this treatment options. In the modern times, we have developed better radiation techniques that allows better disease control with less toxicity. Also, less toxic regimens have been developed. We have better staging modalities, specifically the PET-CT scan, that has helped us to evolve and to offer treatment as a PET-adapted strategies. And of course, we have target therapies that are the novel part of the treatment of Hodgkin lymphoma. Before we get into treatment, there are a few concepts that we need to remember. When we analyze data, especially from clinical trials, survival data is presented in these curves that are called a Kaplan-Meier. And these curves have two axes. One axis is this one, in which which is the estimated survival. So this is the percentage of patients alive or in remission. And we see here that at the beginning of the trial, everyone is alive. And then the second axis is the bottom one, which is time since the end of treatment. And then when we have two groups, we have a research group and a control group. And we see that in this case, there's a separation of the curves. And the next question is this significant? Or in other words, is the difference between the survival or remission in these two different groups related to the different treatments, different research um, medications, or are they related to other factors? Let's keep in mind as well the risk factors because they are important for the next few slides. Also, as mentioned, the pet adaptive strategies are fundamental in the modern management of Hodgkin lymphoma. And this is a PET CT machine. It's very similar to the regular CT scan. The difference is the use of the contrast material. So for PET CT scan, the dye is a sugar dye that is labeled with some radioactive material. And we do know that some types of lymphomas, particularly Hodgkin lymphoma, is very avid for that sugar dye. And here we have examples of the PET CT scan. Let's keep in mind that our body has normal areas of sugar uptake, of which include the brain, a bit in the chest, and a bit in the liver. And as we're going to talk about later, the strategies of the PET adaptive therapies include doing a PET CT scan at diagnosis, then offer 2 cycles of chemotherapy, and then do the interim PET CT scan or PET CT scan after 2 cycles of chemo. And we can see here what are the results of it. For example, in the upper part, we have the initial staging, a patient that have a very little disease, just localized in this area. And we see that the interim PET CT scan or the PET CT scan after 2 cycles of treatment is still positive. Then this patient went and received more chemotherapy, and we see that at the end, there's still evidence of active disease. On the bottom part of this slide, we see another person uh, with severe and diffuse affectation of Hodgkin lymphoma. However, this patient had 2 cycles of chemotherapy, and the interim PET CT scan is completely clear, despite having more disease. And we see that the end of treatment PET CT scan is as well completely clear. So this is in keeping with the complete metabolic response. In other words, one of the single most important prognosis factors in Hodgkin lymphoma is the interim PET CT scan. Patients that have positive interim PET CT scan have a worse prognosis or worse outcomes compared to patients with a negative interim PET CT scan. And before we go ahead with the treatment options, let's try to talk a bit about the different FDG uptakes. So according to how the uptake looks like, we classify them according to the Deauville score. And remember that we have a normal uptake in the mediastinum and the liver. And anything that is less bright than the liver, it's considered to be in keeping with complete metabolic response, which is from 1 to 3, according to the Deauville score. If the FDG avidity is higher or brighter than the liver, then we consider that to be Deauville score either 4 or 5, and that is evidence of residual or active disease. Now, the chemotherapy combinations used for first line are basically these 2 ones. One is ABVD, which is a regimen that was developed in North America. We have very large experience in all centers have very large experience using ABVD, and it is built for different chemotherapy agents. One is the doxorubicin, bleomycin, vinblastine, and the carbazine. And these are given every 14 days in 28-day cycles. Usually, the ABVD is well tolerated and is given as an outpatient. In the bottom here, we have the other agent, which is called the other recipe, which is called the escalated B cup. The escalated B cup is a far more intense and dose-dense chemotherapy regimen that was developed uh, by the German group. And it has some more drugs involved. We have bleomycin, etoposide, higher doses of doxorubicin, cyclophosphamide, vincristine, procarbazine, and prednisone. And this is given every 21 days. Um, as expected, escalated BCOP is more toxic than ABVD. It has more acute and long-term side effects. However, it has higher rates of complete remissions. And one of the most important long-term side effects is actually the risk of infertility. So this is something that needs to be considered when choosing the different chemotherapy agents. As well, because more chemotherapy is involved in escalated BCOP, there's a slight increase in the risk of developing second types of cancers many years after treatment. So going into the PET adapted strategies, the objective of this is to maintain remission rates and reduce the long-term toxicity. Prior to the PET-CT scan, everything was like the regular recipe was for early stage Hodgkin lymphoma, ABVD between 2 to 4 cycles plus or minus radiotherapy. For advanced stage, usually ABVD between 6 to 8 cycles. Now with the PET adaptive strategies, what we have done is that what we are doing is actually offer 2 cycles of chemotherapy, then do a PET-CT scan. And according to that interim PET-CT scan, if the PET scan is negative, then we can safely de-escalate or reduce the intensity of treatment. Or if the other side it is positive, then we have to escalate the intensity of treatment. And how does that look for limited stage disease with no unfavorable factors? We usually offer ABVD times 2. This is followed by the interim PET-CT scan. If the PET scan is negative, we can offer 2 additional cycles of ABVD in 4 in total, or just give 1 more cycle of ABVD plus radiation. On the other side, if the PET scan is positive, then we have to escalate to BCOP and offer radiation. For patients with a limited stage unfavorable, that means with risk factors, the initial treatment is the same, ABVD times 2, followed by PET-CT scan. If the PET-CT scan is negative, we can give ABVD or AVD, which is the emission of bleomycin for 4 additional cycles, or ABVD 2 cycles plus radiation. On the other side, if it is positive, then we have to escalate to the more dose-dense regimen, like BCOP, for 2 cycles and then radiation. In the case of advanced stage disease, that includes stage 3 and 4, and also stage 2 with B symptoms, there are several options. One of them is to give ABVD by 2, again, followed by PET-CT scan. If it is negative, AVD, which is the AVD with the omission of the bleomycin with 4 cycle, for a total of 4 more cycles, 6 in total. We do know that the omission of bleomycin is safe in this population. On the other side, if the PET-CT scan is positive, then we have to escalate to BCOP and offer 4 more cycles of it. Another potential option is to offer escalated BCOP upfront, give 2 cycles, do a PET-CT scan. If the PET-CT scan is negative, we can give 2 more cycles of escalated BCOP for a total of 4 cycles of escalated BCOP, or de-escalate therapy to ABVD and give 4 cycles of it. On the other side, if the PET-CT scan is positive, then we have to give 4 more additional cycles of escalated BCOP for a total of 6. Also, there are new agents moving for upfront therapies. One of them is the combination of Brentuximab plus ABD for 6 cycles. We're going to talk about this in a minute. Now, in terms of radiotherapy, as mentioned, this is used in early stage disease, and the best results are when it is combined with chemotherapy. Um, the newer machines that provide radiotherapy are far more effective and safe than the ones used on the older days. Now, after treatment, we do know, as mentioned earlier, that Hodgkin lymphoma is a highly curable cancer. Unfortunately, about around 20 to 30% of the patients will have refractory disease, or they will unfortunately relapse after treatment. At the time of relapse, treatment would depend on fitness and age. We do know that for younger and fit patients, the high dose chemotherapy and the stem cell transplant is the best alternative. However, transplant is only effective when there's evidence of chemosensitivity. And for that, we need to offer an additional cycles of chemotherapy or salvage treatment. This can be either with a combination of gemcitabine, cisplatin, and dexamethasone, or other regimens like ifosfamide, carboplatin, and etoposide. Once we know that there is evidence of chemosensitive disease, then the next step is to give very high dose of chemotherapy that will try to completely destroy all the remaining Hodgkin lymphoma cells. And this is followed by stem cell rescue or autologous stem cell transplant. After a successful transplant, the long-term remission rates are at 5 years is around 50%. And again, unfortunately, there would be a percentage of patients that will relapse after transplant. Alternatives for this population includes the use of the newer agents like brentuximab vedotin. Brentuximab is an antibody drug conjugate. It's one of the new fancy drugs. Uh, and it is approved for Hodgkin lymphoma after failure of stem cell transplant, after failure of 2 lines of therapy for patients not candidate for transplant, or it is used as well as part of the consolidation strategies after transplant. And the way that the brentuximab vedotin works is that it is a antibody drug conjugate. The antibody is against CD30 cells. I should mention that the Hodgkin lymphoma cells express in their surface receptors that are called CD30. So the brentuximab is built with this monoclonal antibody that binds to the CD30 molecules, the receptor in the Hodgkin lymphoma cells. However, the brentuximab, along the anti-CD30 monoclonal antibody, it also has this these molecules called MMAE that are microtubules disrupting agents. So when brentuximab is infused to a patient, it attaches to the Hodgkin lymphoma cells thanks to the CD30 receptor. Then the cell internalizes the drug, and once inside the cell, the brentuximab releases this microtubule disrupting agents and binds to part of the DNA of the cells and eventually causes the death of the Hodgkin cells. The phase 2 trial that led to the approval of brentuximab vedotin for patients with relapsed Hodgkin lymphoma was published some years ago, and it included about 102 patients that relapsed after transplant. Uh, they found an objective response rate was quite impressive of 75%, included 34% complete responses. And the estimated overall survival, or the amount of patients alive at 5 years, was about 41%. And at 5 years, the progression-free survival, or in other words, patients in remission at 5 years were about 22%. Here we see the graphs from that published paper. And one of the most important things to mention here is that over time, there will be a percentage of people that will have ongoing remission, like we see in these red dots here in the graphs. If we see the bottom graphs, we see that the black line are patients that achieve a complete remission. And this is very important because it shows that patients that have a complete remission, they have a much better survival and a much better and a prolonged remission compared to patients that have only a partial response or that they don't have a good response at all. Also, brentuximab has been used after stem cell transplant in patients with very high-risk disease. That paper that led to the approval of brentuximab for this was published in 2015, and it included 329 patients randomized to two arms. One arm received brentuximab vedotin every 3 weeks for a total of 16 cycles, and that was compared to placebo. And we see that patients that received brentuximab have a longer remission compared to patients that only received placebo. And importantly, this difference was significant, or in other words, it was related to the use of brentuximab. Also, as mentioned above, there is interest in bringing in the brentuximab as part of the first-line therapies. There's a very large trial published a few years ago that it included more than 1,000 patients with newly diagnosed advanced stage Hodgkin lymphoma, and they were assigned to two arms. One arm was AVD plus brentuximab, or ABVD as the standard of care. And we see the progression-free survival of the difference in terms of progression-free survival for those patients. For example, we see here in the blue line, patients with brentuximab plus ABD had a better sustained remission compared to patients that only had ABVD. And this difference as well was significant. Now, one of the most important aspects in the treatment of relapsed refractory Hodgkin lymphoma is the use of immunotherapy. Let's go back to our Reed Sternberg cells, and let's remember that they are surrounded by different types of cells that actually they do belong to our immune system. These cells are macrophages, dendritic cells, neutrophils, mast cells, and the bottom here, they have T cells. The T cells, especially the tumor effector cells, should be able to recognize and to destroy malignant cells. So immunotherapy is actually a treatment that stimulates our own immune system to fight cancer. And one of the reasons why immunotherapy works well in Hodgkin lymphoma is because Hodgkin lymphoma has the ability to become invisible to the immune system. And that's through some very complicated mechanisms called a tumor evasion. Through one of those pathways that allows the Hodgkin lymphoma to do that is the PDL1, PD1 pathway. So we have a very good representation here. So this green guy is our T cells. Our T cells have different receptors in the membrane that activates them, but also they have receptors that switch them off. And the PD1 is the receptor or the molecule that switch the T cells off. And the Hodgkin lymphoma, they have the PDL1, or in other words, they have the key to switch the T cells off. So the T cells know that the Hodgkin lymphoma is there, but they are unable to do anything because they're off, they're inactivated because of the overexpression of this PDL1 in Hodgkin lymphoma cells. And what do the checkpoint inhibitors do, like nivolumab or pembrolizumab, is actually they remove this break. So they allowed the binding of the PDL1 from the Hodgkin cells to the PD1 of the T cells. And that helps the T cells to recognize, activate themselves, and kill the Hodgkin cells or the cancer cells. To this date, there are two checkpoint inhibitors approved for the management of relapsed refractory classic Hodgkin lymphoma. One of them is nivolumab, which is given either every 2 or every 4 weeks until disease progression. The overall response rates with nivolumab is around 70%, with around 16% of complete remissions. The other agent approved is pembrolizumab that's given every 3 or every 6 weeks until disease progression or toxicity. The overall response rates are very similar, around 72%, with 28% of complete remissions. Um, there are some side effects related to immunotherapy, and those are basically autoimmune side effects that include thyroiditis, colitis, enteritis, pneumonitis or inflammation of the lungs, nephrotic syndrome, affection of the nerves or neuropathy, and some few cases of pancreatitis have been described as well. Um, Now, the future looks really promising in the treatment of Hodgkin lymphoma. There are new combinations that are being explored and developed. As now, there is the combination of nivolumab or the checkpoint inhibitor plus AVD. This is for patients as a first-line therapy. There's a phase 2 trial that was published that showed very impressive overall response rates in advanced stage disease with 67% of complete remissions. There is an ongoing phase 3 trial that is comparing Brentuximab plus AVD versus nivolumab plus AVD. There are some Canadian centers participating in this trial. Um, Another novel combination is the use of nivolumab plus brentuximab. There's a phase 1/2 trial that showed the very good response rates in very aggressive disease with 67% of complete remissions. Also, there are new combinations involving brentuximab, nivolumab, plus another agent called ipilimumab, which is a checkpoint inhibitor of a different pathway. The published phase 1 trial showed a very impressive overall response rate of 97% in very heavily pretreated patients with an impressive complete response rate of 79%. Um, Also, there are new antibodies drug conjugates being developed. One of them is the camidanlumab. Phase 1 clinical trial show that heavily pretreated patients had an overall response rate of 71% with a 42% complete remissions. And there is an ongoing phase 2 trial. Um, and as well, there's the development of CAR T cells for Hodgkin lymphoma. And these are CAR T cells against CD30. So CAR T cells have been approved by Health Canada for the use of in cases of relapsed refractory diffuse large B-cell lymphoma and acute lymphoblastic leukemia. So CAR T cells are a specific treatment that uses our own immune system to develop tools to destroy the malignant cells. And what happens is that T cells are extracted or are harvested from patients. Then those T cells are sent to a lab, and that lab manufactures or modifies the T cells so they can express specific molecules in their membrane. In the case of Hodgkin, to express anti-CD30 receptors. So these cells are then infused back. They go inside to the patients, and they have the ability and the tools to recognize those Hodgkin cells and to destroy them. Um, so far, there are only a few trials with CAR T cells in Hodgkin. The first trial was small, only included about 9 patients. The results were modest, overall response rates of 39% with no complete remissions, and a median progression-free survival or time in remission of 6 months. Um, Another newer trial published last year included 41 patients. The response rates were better, 72% with 59% of complete remissions, and at 1 year, up to 36% of the patients were still in good remissions. Um, so as conclusions, the treatment for Hodgkin lymphoma has seen notable improvements in the last decades. Always keep in mind that Hodgkin lymphoma is a highly curable cancer. And for patients that are not cured after first line, there are very good new options, and there are more drugs being investigated and under research. So I wish to thank again to Lymphoma Canada and to all of you for your attention.
Thank you very much, Dr. Rivera, for your excellent presentation on Hodgkin lymphoma. We really, really do appreciate your in-depth overview of the clinical course of this Hodgkin lymphoma, how it's different from non-Hodgkin lymphomas, and also highlighting the different treatment options available for Canadians in both the frontline and relapse refractory settings. It's really great to see the different treatment options that are in research testing at the moment, and hopefully will soon become available for Canadians. I would now like to go ahead and direct our audience to please go and attend the breakout session for Hodgkin Q&A to have your questions answered live by Dr. Rivera. Thank you very much. Thank you, Dr. Rivera, and we will be speaking with you soon. Bye.